Hello everyone, this is Group 6. So me, Loo, Syafiah, Izzat and Husna will present about the serology immunoassay, the rapid diagnostic test. So we will explain about the purpose, principles, methodology, advantages and limitations, as well as the improvement of this RDT.
What is the purpose of rapid diagnostic test? Firstly, what is serology? Serology is a scientific study of serum or plasma, especially with regard to the body's immune system response. Serology test for SARS-CoV-2 can help identify if you have been exposed to the coronavirus and have potentially developed an immune response to the virus. The purpose of serology, a rapid diagnostic test, is to detect the presence and absence of antibodies against virus present in patient's serum by detecting IgM and IgG antibodies to SARS-CoV-2 in blood sample from patients suspected of COVID-19 infection. Immunoglobulin M or IgM antibodies are the body's first line of defense and are produced shortly after someone is infected with the virus. IgM antibodies don't stay long in the body. However, a few days after infection, the body produces immunoglobulin G or IgG antibodies which are sustained in the body. The principle of the rapid test is lateral flow immunoassay, which can detect antibodies against the virus. The cassette consists of sample pad, conjugate release pad, nitrocellulose membrane, which have the test lines and control line, and lastly, the absorbent pad. Let's look at the test cassette more closely. It consists of a sample pad where blood sample and buffer are added to. There is a conjugate pad, consists of preset antigen tag with gold and gold tag control antibody. There is a test line which consists of pre-attached antibody to detect antibodies of interest in the blood sample. At the control line, there are pre-attached control region to detect gold tag control antibody to show validity of test. Basically, a quality control to see if the test works well or not. So let's look at the flow of the test. When the blood sample is added to the test, the antibodies contained in the sample will start to flow down the strip by capillary action. At the conjugate pad, antibodies that are present from the blood sample will bind to the antigen of interest, forming an immunocomplex. Then it will be caught on the test line by the pre-attached antibody. At the control line, the control antibodies will bind to the control line to show that all portions of the test worked correctly. Then excess antibodies, tagged antigen, buffer, and blood platelets finally will reach the absorption pad. In the case of testing for COVID-19, at the conjugate pad there will be SARS-CoV-2 recombinant antigens conjugated with colloidal gold preset on it. At the nitrocellulose membrane strip containing an IgG line, or G line, will be coated with anti-human IgG. On the IgM line will be coated with anti-human IgM. So when a correct volume of test specimen is dispensed into the sample well of the test cassette, the specimen migrates by capillary action along the cassette. The anti-SARS-CoV-2 virus IgG, if present in the specimen, will bind to the SARS-CoV-2 conjugates. If IgG is present in the specimen, the immunocomplex will then captured by the anti-human IgG line, forming a burgundy-colored G line, indicating the SARS-CoV-2 virus IgG positive test result. The anti-SARS-CoV-2 virus IgM, if present in the specimen, will bind to the SARS-CoV-2 conjugates. The immunocomplex is then captured by the anti-human IgM line, forming a burgundy-colored M line, indicating a SARS-CoV-2 virus IgM positive test result.
So the first thing we need is the material and apparatus in the Select Q SARS-CoV-2 IgG/IgM rapid test, an in vitro diagnostic test. And this is the reagents and materials provided in the test kit, which is a test cassette, the sample diluent, the transfer pipette, and also the IFU leaflet. And now we need a conjugate pad for the SARS-CoV-2 antigen-coated gold particles, and we need a G line and M line. We will use the anti-human IgG and IgM. For the C line, we will use the gold anti-rabbit IgG, and we need a sample buffer. We need negative control for the negative human serum, and we need a positive control using the negative human serum spiked with positive serum. And we need a timer. And the first step will be the specimen collection and preparation step. The three types of specimen we use is the plasma, the serum, or the whole blood. And these three types of specimen will be collected by using V-knife puncture technique. Plasma will be collected into a lavender or blue top collection tube containing EDTA or citrate, while serum will be collected into a red top collection tube containing no anticoagulants. And these two types of specimen will be separated by centrifugation and then withdrawn into a new tube. We need to consider any materials of human origin as infectious, and thus we need to handle them using standard biosafety procedures. And here is the test procedure. When we are using a frozen sample, we need to thaw it to the room temperature and then mix them well once thawed. But if we are using a fresh sample, we need to place the test device on a clean, flat surface without thawing it. And then we need to label the device with a specimen ID number. And then by using a transfer pipette, we need to transfer 10 microliter of the specimen, which is the serum, the plasma, or the whole blood, into the center of the sample well or specimen well or as well, and to make sure that there are no air bubbles and the volume shall not exceed the as well. Then add 2 drops of the sample diluent immediately into the as well. Next, we have to set up a timer and read the results in 15 to 20 minutes. The results will be invalid after 20 minutes, and to avoid confusion, discard the test device after interpreting the result. To interpret the result, we have to know that for a valid assay, C line must always be present. So this is the result of the control shall be look like. For a negative control, no line should be visible, while for a positive control, G line or M line or both lines will be visible. For a positive valid assay, in addition to the presence of the C line, if only G line is seen, then the result will be IgG positive, showing a recent or previous infection. But if only M line is developed, the result will be IgM positive, and this is a acute or recent virus infection. And if both lines are seen, then the result is IgG and IgM positive or reactive, and this is a current or recent virus infection. For a negative valid assay, when C line is present, no line is developed. But a negative result do not rule out the infection, so a follow-up testing with a molecular diagnostic test is necessary. And we have to know that the results from antibody testing should not be used as the only basis to diagnose or exclude this infection. False positive results may occur due to the cross-reacting antibodies from previous infections, and the positive results should be further confirmed with alternative testing methods. For invalid assay, the C line does not develop. So even though G line and M line is seen, but if C line is not present, then the result shall be considered invalid. What we need to do is to repeat the assay with a new device.
For the advantages and limitations in rapid diagnostic tests, there are some advantages of RDT, which is simple and cheap, where the usage is by just putting the sample in the specimen provided at the tools, and the result can be read out after 15 to 20 minutes, which is quite faster. So this RDT is easy to handle as it can be run without the need of any special equipment or electrical supply. Next, RDT also does not require any highly trained staff to conduct the test, as anyone who is knowledgeable or anyone who knows how to use the tools correctly and read the result can actually carry out the test. And lastly, the advantages of RDT is it does not require a certain temperature to store the device, and it can be run the test just at room temperature, which facilitates the testing outside of laboratory settings. Next, for the limitation of rapid diagnostic test, the first limitation is we cannot get the exact statistical data as RDT is not a quantitative method. So quantitative method is more precise as we can get to generalize the whole sample population and help with the decision making. The second limitation for RDT is it can cross-react with other antigen viruses besides COVID-19 viruses such as human coronaviruses that cause the common cold. So these may give false positive results showing that a person is infected when they are actually not. And lastly, RDT may not be able to detect very low antibody response in order to inform actions needed to determine the course of treatment. This can result in a negative impact as the disease transmission may have already been passed to other people.
So the proposed method for the improvement was focusing on the sensitivity. It is by introducing the capture and detection reagents that has high affinity or ability for the analyte. There were two types of reagent, the natural and the synthetic. Natural is by using the streptavidin biotin system. As the assay reagents, it is highly resistant to biochemical interference and naturally multivalent, in which the streptavidin can bind to 4 biotins. So for the second type is synthetic. It is by using the computational models. It can target specific epitopes, search over for multiple interdependent reagent characteristics, and also introduce multivalent bindings. The example was hemagglutinin binding protein that is specifically designed to bind to different analyte epitopes as detection and capture probes in an influenza lateral flow assay. So, however, this proposed method has its limitations. It does not align with the desirable characteristic of lateral flow assay, in which integrated and have a low cost and also rapid.
That's the end of this video. Thank you so much for watching.